Hello and welcome to the Evidence-Based Urgent Care Urgentology Podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB Medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this new program from EB Medicine, the Evidence-Based Urgentology Podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points, and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can subscribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier.
Hi, everyone.
Good afternoon, good evening, or good morning, whatever time of day you're listening to this lovely podcast. We'd like to welcome you.
The April issue, which we are going to talk about today, is entitled The Urgent Care Evaluation and Management of Elbow and Forearm Pain in Children. It's part 2 of what we discussed last month for adults.
Yeah, they were going to make some kidbits out of it, but the kidbits ended up being like 4 pages long because there's just so much about kids that's different than grownups and elbow and forearm. So we decided to make it a whole other issue and definitely enough content for that. This journal was authored by Natasha Pierre, MD, who's a pediatric urgent care physician in Dallas, Texas, which, by the way, is where you're going to find the Urgent Care Association annual convention the first week of May. So check us all out there. I would be happy to meet you.
Yes, we hope to see all of our listeners there. And plus, there were 3 peer reviewers for this issue, and they were Danielle Federico, MD, FAAP, who's the Director of Pediatric Urgent Care in Farmington, Connecticut. Emily Montgomery, she is a physician, also has a MHPE, and she's a fellow of the American Academy of Pediatrics. She's Director of Education in the Division of Urgent Care at Children's Mercy, Kansas City. She's also Associate Professor of Pediatrics at University of Missouri, Kansas City School of Medicine in Kansas City, Missouri. And then I think right across the river, right? Clinical Assistant Professor of Pediatrics at the University of Kansas Medical School in Kansas City, Kansas. And then our 3rd peer reviewer was Marissa Rodriguez, MPAS, PAC with a CAQ in Pediatrics. She is the Director of Physician Assistant Training and Procedure Training for PM Pediatric Care in Comic, New York. Hey, Tracy, how about an introduction and a little bit of anatomy and differential diagnosis for pediatric elbow and forearm pain?
Well, of course, we got to start somewhere. So like I said, this was a whole issue because kids are different. Their developing bones make injuries really different, as well as their evaluation and management is a little different than it is with adults. So they're also susceptible, like adults, to chronic overuse injuries, especially now with the trend of kids to do sports younger and younger, as well as the more intense training that goes along with that and the year-round sports. Sports used to just be a season, but now kids play sports all year round, not just with the school teams, but with travel teams and local teams. And so they do a lot more than they used to when we were kids. The most common injuries are the foosh, or the fall on the outstretched hand, usually in a playground injury or a contact sports or some other activities, most common for those injuries. And then elbow and forearm injuries in children, believe it or not, represent more than over a quarter of all sports-related injuries in children and adolescents. So this is huge. There's a lot of this going on. Overuse injuries occur in tennis, baseball, gymnastics, swimmers. Basically, think about anybody that's moving the elbow over and over again for whatever sport it is that they're doing. There's osteochondritis dissecans, where your bones basically dessicans dry out. So the joint space can have some drying type thing, usually from repetitive loading injuries. So in this kind of think of gymnastics. So you're over and over again, tumbling, landing on your hands, but also weightlifting, lifting and forcing your elbow against heavy weight. So prompt recognition of both the injury as well as the overuse prevent long-term disability, growth disturbance, which can occur in kids that have injuries to the joints and bones, and chronic pain. So I'm not going to really go over anatomy too much. You all know what bones make up the elbow. But the most frustrating things about kids, and the frustrating things to remember, is the ossification centers in the elbow. So when they appear, when they fuse, and knowing that makes it difficult. I remember as a student looking at an elbow going, oh my goodness, look at all those things. How do you tell the difference between an ossification center and a fracture? And sometimes that does make it a little bit difficult. So there is a mnemonic for when they appear, which is crito, Critoe. So think of capitellum, radial head, internal or medial epicondyle, trochlea, olecranon, and the external or lateral epicondyle. And what makes it kind of easy to remember what year the age the kid is when it develops is just think it's every other odd number. So the initial capitellum appears at 1 year, radial head at 3, medial epicondyle at 5, trochlear area at 7, olecranon at 9, and then the lateral epicondyle at 11 years. Fusion is a little less predictable. Usually it starts with the lateral epicondyle, then the trochlea, then the capitella, and then finally they all fuse together with the medial epicondyle. Would that make the mnemonic ETCI? Unfortunately, there really is no mnemonic for that because there really is no specific timing of how these things fuse. So because of this anatomy, like I said, physio fractures are more common than ligamentous injury. It's easier to disrupt that than it is to mess with one of your ligaments. So the differential diagnosis in elbow and forearm can really vary quite widely from just mild contusions to even limb-threatening injuries and compartment syndromes. But most problems with the elbow are usually due to trauma or overuse. The exception on this is nursemaid's elbow, one of my favorite things to do in urgent care. There's very few things that we can fix right away. This is one of them, and it really is kind of gratifying to pop that sucker back in. Mom's
Definitely.
happy, kid's happy. You go from screaming kid to they get this look on their face like, oh, I'm all better now. Like I said, very few things that we can fix right away. So this is kind of gratifying. Don't forget about NAT or non-accidental trauma, especially if the story doesn't fit with the injury. I say this over and over again with all of our extremity injuries. And it took me a long time to figure this out until I got a lot of experience. But, your mechanism of injury is going to completely predict the type of injury that you have. So if those two don't fit, the mom tells you that the 1-year-old fell out of bed and somehow they have a spiral fracture. Well, that doesn't fit because spiral fractures from a twisting motion. So every once in a while, you won't really know your mechanism of injury, but most of the time you can get a good sense of what's going on. So if they don't fit, kind of think about the non-accidental trauma because mechanism predicts the type of injury. And if they don't jive, just be very suspicious about that. Couple other things with the elbow that we're not really going to talk about here. You can find a little bit of it about an issue, or you can look up if you're really interested. Infections of the elbow, like a septic arthritis, or also malignancies. Very rare, thank God, but Ewing sarcoma, chondrocarcinoma, those sorts of things may present as a child with just pain. So definitely have to be diligent and kind of think about that. Once you've gotten through the thinking about how things happen, how do you evaluate the patient? Here you are, you have this kid that's got an elbow or forearm injury or pain. What do we do from here, Joe?
Well, urgent care ortho. Our tools of the trade are history, physical, and in terms of our diagnostic testing, for the most part, it's going to be x-ray. Because in terms of frequency, many or most of the pediatric elbow problems and forearm problems we're going to see involve trauma. We just want to be mindful of the associated trauma. So start with your ABCs and don't kind of overlook head and neck injuries as a potential complication of a clinical situation where a painful elbow is chief complaint, or there's an elbow deformity and you're immediately going to go for that. Keep in mind your general survey and the other things that are important. You had mentioned understanding the mechanism of injury, particularly if it's acute, is important. It can sometimes help you predict what you're going to see, kind of your pretest probability for certain stuff. But it's also important with sports, if there's overuse or repetitive strain type injury, it's going to help you hone your diagnosis. Think about diagnostic tests. Be on the lookout for rare but really important things not to miss, like septic arthritis, osteomyelitis, or bone cancer. You had talked about that. These are not very common, but primary bone tumor is more common in kids than grownups. And so if there's a non-traumatic onset, you can be a little bit more suspicious of that. And then obviously if there's fever, chills, or other systemic symptoms, again, the thing could be septic arthritis, osteo, or even juvenile rheumatoid arthritis in its presentation can have some systemic symptoms as well. The article highlights some of the pediatric specific issues in getting a history, like kiddos' potential inability to grade their pain. So using something like the FACES scale and have them point out the smiley face or the frowning face or the crying face can let you know the relative amount of pain that they're in. And then also our own observations as clinicians, we can include in the notes like that they're holding the arm fixed in flexion or not using the arm at all or nonstop crying. Those sorts of things can also kind of enrich the history and help somebody who's looking at the note later know about the situation. Our red flags in terms of history are going to be those systemic symptoms or really significant elbow pain without trauma. Those are going to clue us into those conditions that you talked about in the differential diagnosis. And then last but not least, you also mentioned this. We have to think about non-accidental trauma, which is in that overall rubric of child abuse. Some of the red flags might be a history that's inconsistent with the injury, or like a 6-month-old who's not rolling off a couch, or inconsistent histories that are being given between two caregivers. Those are things that are going to heighten our suspicion. That's a whole issue in and of itself. I don't know whether, hopefully, there'll be an evidence-based urgent care about evaluation and management of non-accidental trauma, because it can be complicated in and of itself. And hopefully you know what to do for that, and your facility has a protocol. A physical examination, like other orthopedic type issues that we've talked about, is going to start off with inspection, looking for deformities, looking for ecchymosis, erythema, wounds that might help us clue into either an infection that's entered or open fractures. We want to test range of motion actively and passively. I want to palpate the various landmarks around the elbow, assess for strength, and then, of course, finish up with our neurovascular exam. And again, like we talked about in adults with elbow injuries, I would have to say, and it's not really quoted in the article, but I would say elbows are probably the most common injury where you get some kind of tingling associated with it that could be significant. There's a lot of nerves that cross over the elbow, and similar to adults, they can get injured or get some pressure type phenomenon, not only with the injury itself, but after a splint is put on. So it's important to do your neurovascular exam at the beginning and then also after splinting. In terms of diagnostic studies, x-rays are going to be our mainstay for the forearm, because it's a long bone. You can get away if you're just looking at the forearm with 2 views, AP and lateral, but elbow, you're going to want to do 3 views. There are a number of anatomic landmark type lines that need to be kept in mind when we're interpreting elbow x-rays, in addition to the crito-mnemonic that you talked about in that wonderful, thankfully, 1, 3, 5, 7, 9, 11 that goes along with CRITOE. If you can just keep that straight, it can help visualize when these rounded pieces of bone or little chunks of bone are beginning to appear around the elbow. But in terms of alignment, the anterior humeral line and the radiocapitellar line are important to look for. If those are out of alignment, then you can suspect a fracture related to the bones that are involved in forming that line, even if you don't see a lucency. Similarly, the fat pad signs, any sort of a sail type configuration to the anterior fat pad, which is normally somewhat visible, but it becomes a lot more visible and a lot more angular in terms of what it looks like on the lateral view. And then any visualization, similar to an adult, of the posterior fat pads considered abnormal. In those cases, what that really indicates is that there's intra-articular fluid. That causes those fat pads to elevate away from the bone and become visible on the x-rays. In the setting of trauma, that's almost always going to be some type of hemarthrosis or lipohemarthrosis. We may or may not see that, but we'll see the fat pad signs. And that indicates there's an intra-articular fracture, even if we don't see a bony lucency. And in the setting of no trauma, we might suspect an effusion in that situation, which is unusual with an overuse injury, but might indicate either septic arthritis or juvenile rheumatoid arthritis or something like that. Tracy, how about treatment for these variety of elbow maladies that we're talking about?
All right. Well, if you've got traumatic injuries, which probably is the majority of what we're going to see in urgent care, no matter what the injury is, we're talking probably, if it's a fracture, some degree of immobilization and pain control. So that's pretty easy. Overuse injuries, the solution to that is activity modification. If it hurts, don't do it. Okay. Not quite that simple, but basically taking out of or reducing sports. So if it hurts to throw your arm, don't throw your arm. This can be really challenging, especially with, really highly motivated competitive parents. I mean, what do you say to, but the finals are coming up, or he's got a tournament or something like that. It's like, well, I'm telling you what you need to do, and it's kind of up to you to decide what you want to do. Nursemaid's elbow reduction, again, something we can do in urgent care. Reduction of big fractures or dislocations, probably not something we're going to do. For the nursemaids, there's several different ways that you can reduce a nursemaid's elbow, but the issue and most of the evidence and me recommend doing the hyperpronation method. It's really very, very easy, and it approaches about a 95% success rate on the first attempt. So that's pretty good. I used to do the supination selection method, which is not wrong, but if you're going to try anything or learn anything, learn the hyperpronation method first.
When did you learn that? I was like 25 years into practice before I even heard that you could do it that way.
Yeah.
It was all about flexing the elbow and hypersupinating. It's interesting that extension and hyperpronation, the exact opposite, can work as well. But I don't know whether that was introduced later as a technique, but really interesting. I like it better too. I agree with you.
Yeah. I mean, I don't know, maybe the past 5 years or so, maybe 10 years I've
Yeah.
started doing that. Usually you'll hear a pop or a click as soon as that pops right back into place, and then the child is willing to use the arm. A lot of times you'll get that aha moment where they'll just look at you like, what was that? And they'll maybe give out a little grunt or a cry or something, and then all of a sudden they're all fine. You may need to wait a few minutes because they may have a little hysterics over that. Many times I'll just do it while I'm doing my exam. I know by history and the way the child looks that this is going to be a nursemaid's. And as I'm doing my range of motion, I'll just do that hyperpronation and we go. Don't even describe it or anything. It's like, oh, I was doing range of motion and I fixed it. So a lot of times a good trick to do is to do your exam on the opposite arm that's unaffected. That way you'll kind of gain the trust of the child and they know that you're not really going to hurt them. So when you go to grab that affected arm, they're not going to pull away from you or get all hysterical on you. If the child won't really use the arm after you put it back in place, give it a few minutes. Usually after 10 or 15 minutes, you come back in and they're in there flailing their arm around and all playing. But if the child is still skeptical, you want to have them reach for a toy or a snack or even mom or dad. And there are many tricks here to try and get that kid to start using that arm. But I find a lot of kids with injuries, as soon as that injury is better, they suddenly forget about it and they start using it again. If for whatever reason this is not successful, it's been 15 minutes, the kid still isn't using the arm or holding it against their body, then you're kind of at a loss at that point to know what's going on. You want to try and consider some imaging and look at it. And if you look at the imaging and there's some sort of fracture suspected, you're going to want to put it in a long arm splint or sling and then have them follow up with peds ortho. If I don't suspect any fracture and I'm pretty sure it's in and the kid just still won't use it, a lot of times I'll just wrap it in an ACE wrap and I'll have them follow up with the pediatrician or orthopedics the next day or in a couple days just to make sure. But usually by then they're using the arm. Medial epicondylar apophysitis, also known as Little League elbow, is an overuse injury. The solution to that is no or little throwing for 4 to 6 weeks. And that pretty much kills their whole season if they're doing something in sports. And you could see how they might be resistant to this, especially if they're a junior trying to get a college scholarship or they have that tournament coming up. Also, using your NSAIDs and your ice. PT is really good for this because they do some shoulder and elbow strengthening and it prevents the kid from developing the injury again. Lateral epicondylitis, usually in tennis players or golfers, pretty much the same as it is in grown-ups. You want to limit that inciting activity that caused the problem. But in this case, unlike the little leaguers, you can use those forearm straps that they use for tennis elbow, and that reduces the stress on the tendon and it also provides support. You can do some physical therapy, some ice, and some NSAIDs for this as well. They didn't really mention KT taping here. They did in the adult version of this article, but that may also be useful in kids. Supracondylar fractures, a little more serious here. You want to do some very close monitoring with orthopedics. There's a really high rate of malunion for these. If they're not very minimally displaced, you can put them in a long arm splint in a sling and have them follow up with ortho in 5 to 7 days. But if it's significantly displaced or an open injury, obviously you want urgent orthopedic evaluation and you may have to send that patient to the emergency department. And this really goes for all fractures on any body part. Nobody should leave without immobilization. So if you're sending that person even to the emergency room where you know they're going to take down that immobilization immediately, you should still immobilize them for comfort. Having that injured part flopping around on their way to the emergency room is not good for comfort for them. Doesn't have to be pretty. It doesn't have to be perfect. It just has to work. So immobilization really does go a long way for managing pain. Give them some ibuprofen or whatever you have for pain because you know they're going to be sitting in that waiting room for a long time. So make them as comfortable as possible. Again, Joe mentioned this earlier, don't forget to assess neurovascular status, and that's going to be before you do anything with them, but also after you do anything with them. So as soon as you splint them or put them in a sling, you want to make sure that you document that neurovascular status and document it. If you didn't write it, it didn't happen. So make sure you write that down. Something we don't see too often in urgent care, at least I don't anyway, is green stick or complete forearm fractures. In those cases, they're going to definitely need some ortho. So pain control, splint, and semi-urgent evaluation. Sometimes these are treated definitively with just casting, and sometimes they need surgical repair with a plate, some screws. It's ortho's place to make the call on that, not yours. So make sure that the family knows that this is a work in progress. They're going to need to follow up with orthopedics. So just a little word about ortho evaluation. This article really recommended anything that was displaced or worse than the minorest of fractures should really go to the ED for emergent evaluation by an orthopedist. I got to tell you, that doesn't always happen. Many EDs don't have ortho available. I know the one closest to my urgent care barely ever has ortho. And they pretty much, unless it's an open fracture or something that has neurovascular compromise, they splint it and they send it out to be seen by orthos and outpatients. So there's nothing worse to send somebody to the ED for definitive care only to find out that the ED really didn't do anything except splint them and send them out for outpatient referral. So know what goes on in your area. If it's possible, when I was still in upstate New York, we had lots of relationships with our local orthopedist. We could even call them or call the PA that was working with them and see if they're willing to see the patients the next day. They used to leave open appointments for those things. So if you can have that pre-existing relationship, that's a good idea. That'll expedite care for that patient. I'll also find out, like I said, what your ED is capable of. If you have something bad, are they just going to ship it to the tertiary care or the teaching hospital? Don't make that poor patient take an extra step and go to a facility that's just going to send them somewhere else. So, like I said, save them an ED visit, but make sure you have some contingency plans. So, if you send them out for outpatient follow up tomorrow, tell them what they're going to need to do if they can't get into the ortho tomorrow. You'll save the patient some time and some money, and potentially what we all strive for is Google reviews. So, you don't want them to say that that doctor sent me to the emergency room and all they did was give me an ibuprofen and send me home. So, plan this ahead of time, know what your capabilities are ahead of time. So, I didn't mention physio fractures. We didn't say much about that, but they can result in premature growth plate closure, and that can cause some normal growth and maybe even some shortening of that limb. So you want to be aware of that. And those are most common in ages 10 to 16. These are the Salter-Harris fractures. So I recommend there's a whole big part in the article about these. So make sure you review those because it is important to know. Sometimes you don't even really have to know it. You can just look it up. But, you have to be aware of it. If you have any concern that, hey, is this a Salter-Harris? Is this just a normal variant? Your go-to here would be x-raying the unaffected side because most people are pretty symmetric and you can compare one to the other if you have questions about the morphology. Is it a fracture? Or is it just a growth plate? If you are concerned that there's some sort of growth plate injury here, you want to splint and sling them and have them follow up with ortho as soon as possible. And when I say as soon as possible, I don't mean today, maybe not necessarily even mean tomorrow. Usually it's within a week or so. Just a note about type 1 Salter-Harris fractures. The only finding really may be tenderness at the growth plate area. The x-ray may even be completely negative. And we used to think this was a big deal, and people were going to end up with limbs that are 2 inches shorter than the other. But now we're starting to think maybe that's not such the case. Evidence is really starting to show that it's probably not a big deal. It's just a discomfort and an inconvenience and probably not going to result in any kind of long-term deficit. So you can put a removable splint on these patients if you suspect them. And they should follow up in 7 to 10 days for a repeat x-ray just to make sure there was nothing more serious going on there. And they should be examined too. And this can even be done by the PCP, by the pediatrician, or even your office if you don't have ortho nearby or you don't think they have readily accessible orthopedics. Open fractures, again, we mentioned this before, ED, no questions here. You got an open fracture, that patient's going to the ED. And the Montesia fracture, which is when the ulna will break and the radius will dislocate at the elbow. So you need to sometimes have a really high index suspicion for this because it can be hard to diagnose. So if you see a fractured ulna, make sure you look really hard at the proximal radius to make sure it's not dislocated, because it might be. If you have any concern, these people definitely should be evaluated by ortho because it can cause, one, some issues with healing, but also some neurovascular compromise. So most of these should be sent to the ED. Again, provide them with some pain control and immobilization before you send them off to the emergency department. Okay, so is there anybody that we really need to be specifically concerned about? Are there any special populations here? Because we know there always are.
Sure. Well, our special populations this month include the youngest of the young, neonates and young infants. They're sometimes difficult to examine and impossible to get a history from, so we need to hone our approach. I've talked about some of that earlier. And as well, not very common, but again, that's why we consider special populations because they're uncommon and the population in and of itself can clue us into the differential that's specialized for them. But things like birth injuries, including a brachial plexus palsy, or congenital radial head dislocation, something we need to think about in those really, really young kiddos. And then, of course, non-accidental trauma that would be in any kid, but more so in the younger child. Immunosuppressed kids, such as those with leukemia or ongoing chemotherapy for any cancer, HIV, sickle cell disease, and transplant recipients are all at higher risk for osteo, septic arthritis, and actually delayed fracture healing. So that may represent to the urgent care with ongoing pain or worsening pain because the fracture hasn't fully healed and they've returned to activity. If there's any suspicion of any of this kind of stuff, it's sometimes hard to sort out. So those kids are going to get referred either to the ED for ortho consultation, or like you said, if you have the ability to send them right to an ortho, you can do that. The last group in the special populations category would be kids with neuromuscular or connective tissue disease. So this is things like Ehlers-Danlos syndrome or Marfan's. The loose ligaments that go along with this, so the lax ligaments can lead to a greater chance of recurrent joint dislocations. So you might be seeing them for the dislocation, but because they have recurrent dislocations, there's osteoporosis that can develop from reduced usage, so they can get insufficiency fractures. Those are just, again, things that you want to consider more likely to see in this population and require more careful decision making. And ortho is going to be involved in ED referrals a lot more commonly in them than our usual kid with elbow or forearm complaints. How about controversies in cutting edge?
Yeah, you know what? I just want to mention a special population of a case that I saw, which was really kind of bizarre. I guess kid had a pathologic fracture of the elbow in the distal humerus area with no trauma. It just spontaneously broke. And it was actually a relative of somebody that I worked with. And he was a teenager. And it turned out that they did surgery to replace it. And his bone was soupy on the inside. And it turns out that he had really significant kind of acute osteoporosis from nutritional deficiencies. It turned out he was anorexic and they didn't even really realize it. And he had such severe nutritional deficiencies that he ended up with a pathologic fracture. And that's how it was diagnosed. He did fine
Wow.
eventually, but just one of those crazy things that, maybe stick in the back of your head sometimes. So
Yeah, the fracture was a symptom of something, a different additional problem. Wow.
exactly.
Mhm.
All right. So controversies in cutting edge. Torus fractures or buccal fractures, we see those all the time. Will
Mhm.
fall with sort of a trivial injury with an outstretched hand, or actually one of my kids ended up with a torus fracture after her sister kicked her off the bed and she put her outstretched hand against the wall and had a torus fracture. We used to put casts on these people for 4 to 6 weeks, but honestly, most of the research now and the evidence is showing that conservative management is probably just completely fine. And I've been doing this for some time. They're so stable. It's really more about pain control than it is about immobilization. These bones aren't going to break, that you're not going
Mhm.
to complete the fracture or anything like that. It's just a dent in the bone. I tell the parents, it's like if you snap a tree branch and it doesn't completely break, it's just a little bit unstable. It's not anything that's going to break further. So a simple removable Velcro splint is fine, or brace. You do some ice and some NSAIDs for 3 to 4 weeks, and then you can discontinue that when the symptoms resolve. They don't even really need a follow-up appointment. You can just tell the family when the kid feels better, that's when you can stop using the brace. And I usually tell them when the child forgets about it and stops putting it on in the morning after they get out of their shower, you can pretty much stop wearing it at that point. So if necessary, you want them to have some follow-up, it doesn't have to go to ortho. Peds can take care of it. But if you want to send them to ortho, you can. You wouldn't be wrong to do that. But even your office can follow up with these people if you want to and decide whether or not they need to keep wearing the brace. Ortho, like I said, is probably not completely necessary. And there's really no change in outcomes with this strategy. They heal just fine and they can completely get better with minimal to no intervention there. Another controversy in cutting edge, open fractures. Now, I was shocked when I read this, but I actually
Mhm.
looked for the reference and read it. But in some cases of open fractures, if they're really mild, they have this grading system now. So if it's one of the lower grade, some are not doing surgery to fix these. Eek. They don't open them up and flush them all out to prevent infection. They just give 3 days of antibiotics and they get all better with no worse outcomes than people that do have the washout. Let ortho decide on that one. This is not your decision. Don't flap a Band-Aid on it and call it a day. You need to let ortho make that decision. Sedation may attempt simple reductions in urgent care if you have a way to do some pain control. So intranasal fentanyl is up and coming for pain and sedation. I know a lot of EDs are doing this. And some urgent cares are doing this as well and developing protocols on this. Probably most likely more a pediatric urgent care would be doing this
Mhm.
rather than a standard urgent care, just because we don't have much experience with that and it doesn't come up very often. But look for this in the future. We may be squirting fentanyl up the kid's nose as opposed to the Narcan we're squirting it up the grown-up's nose. But it's possible. Ultrasound can be used to diagnose nursemaid's elbow. I mean, honestly, I don't really know why. It's pretty straightforward when you see kids with nursemaid's elbow, but you can use ultrasound to look for that. And you can also use ultrasound for guidance for injections or any aspirations you want to do. And the other thing that's cutting edge, we can help with prevention of sports injuries. So educate the parents and coaches. We should be doing pitch counts on kids that are throwing baseballs and make sure they get proper rest, make sure they don't have 8 hours of practice every day of the week, or they should really not develop overuse injuries as young teenagers. That's just not fair. So, definitely something you can have a communication about with a child and a parent when you see them for these sorts of things. So, meat and potatoes here, 5 things that'll change your practice. Give them to me.
Sure. Number one, be sure to utilize a pediatric geared approach for your history taking and your physical examination. You talked about distraction, kind of examining the uninjured limb first and gaining that child's trust and then moving over to the other side. That history taking should also help you discern non-accidental trauma once you kind of put that together with the injury and see if it all makes sense. Number 2, remember your mnemonic and that 1, 3, 5, 7, 9, 11 when you're interpreting elbow x-rays. It's helpful along with your fat pad signs to tell whether things are normal or not, in addition to any lucencies and fractures that you actually see in the bone. Number 3, always assess neurovascular status with elbow injuries, with any injuries, even if there's no obvious deformity or doesn't look like there could be something wrong. It's important to just do your usual checks. And then if the splint or some type of a sling or something is placed on the body, you want to do that afterwards as well to make sure it's not too tight. Number 4, kids get a variety of pediatric specific fractures. You talked about Torres fracture, green stick fracture, Salter-Harris injuries. The exam might actually be fairly normal because there's no deformity associated with any of these. But if there's significant pain, even if there's no deformity, go ahead and get the x-ray when in doubt. You might see something that's important to diagnose. Your grade 1 Salter-Harris fractures you're not going to see, but you can infer. Anything more than that, we'll be able to see and discuss the x-rays using shared decision-making with the parent. And then number 5, you had talked about this. There are 2 techniques for reducing a nursemaid's elbow. Studies suggest that the extension hyperpronation has a higher first attempt success rate. So that should maybe be our go-to. And then we can do the other one if after re-examining the child 10, 15 minutes later, they're not using the arm, you could do the other technique. Or if the history is a little bit more suspicious for a fracture, to consider getting an x-ray in that case. You won't see the nursemaid's elbow on x-ray. It's not necessarily to confirm that, but it's just if your reduction didn't work, then you need to kind of second guess, is it just that my reduction didn't work and I can try the other technique, or is there more significant force that I maybe wasn't thinking about initially in terms of the mechanism of injury? How about points and pearls? Our most salient points and pearls.
There you go. Salient. I love that word. Yeah, so some of these are a little repetitive. Again, the more times we say it, the more it's going to stick in your head. So I know we're repetitive here, but you'll remember. Know your growth plates. Remember, we talked about the crito. This may change your management compared to adults because grown-ups don't have those growth plates. Distraction may make your exam or treatment easier. Don't forget about pain control. Just because they're little kids doesn't mean they're not in pain. So give them some ibuprofen or intranasal fentanyl. Nursemaids is clinical. You don't really need some x-rays there. Very satisfying. Know the technique. Overuse, rest, even if it's painful to tell them to rest. You need to make sure that you tell them, the reason this is messed up is because you're doing too much. You need to back off. So as difficult as that may be to tell the parent or the kid, that's one of the things that you got to do. Minor fractures can very easily be managed in urgent care with outpatient referral. We don't need to send everything that's broken to the ED. Understand the implications of Salter-Harris fractures as far as that is on growth and limb length and that sort of thing. And that Salter 1 is not a big deal, that we can take care of that. Be on the lookout for Montasia fractures, which is the radius dislocation in association with an ulnar fracture. And this may have serious consequences, so make sure you don't miss that one. They don't come up very often, so be on the lookout for that. Again, we said not all fractures may show up initially, so if you're suspicious, repeat the x-ray in a week and immobilize in between. Always assess for your neurovascular compromise initially during your initial evaluation, but also after you do immobilization. And not only do you have to do it, you have to document it, because if you didn't document it, you didn't do it. Don't forget about the non-accidental trauma. I think we've been pretty repetitive about that. For everything, no matter what disease or injury we're talking about, always provide clear return precautions and contingency plans in case things don't go as planned after you discharge them. In the elbow, warn of compartment syndrome and neurovascular compromise and what to do if you're worried about it. Those fingers turn blue, or you don't have good capillary refill, or the pain is out of proportion, or there's numbness and tingling. Make sure they know that they need to see somebody sooner rather than later, because the consequences can be pretty severe. Know your local ED and ortho capabilities, because it may alter your disposition. So plan for these things ahead of time and know where you're going to send that patient. So that about wraps it up for us today. This is everything on pediatric elbow and forearm injuries. We hope you enjoyed this episode of Evidence-Based Urgent Care, the Urgentology podcast.
Yeah. Take care, everyone. Hope to see you in Dallas in a couple of weeks.
We will be there. Evidence-Based Urgent Care will be there. And EV Medicine has a booth. So come on, stop by and say hello.
Take care, everyone. Bye-bye.
I want to thank everybody for listening to this month's Evidence-Based Urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site. That's evmedicine.net to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.